Hello, everyone. My name is Kristina Johnson, and I had the opportunity to conduct my research under Dr. April Carson with the School of Public Health and UAB Step Up program. My research focuses on the association of neighborhood level poverty with prevalent diabetes in urban and rural communities. In recent studies, residents of low-income and rural neighborhoods often have less access to supermarkets and healthy foods that may contribute to poor health outcomes. According to the Department of Health and Human Services, as of 2021, the federal poverty level for an individual is $12,880, and a family of two, $17,420, and on and so forth. The federal poverty level is available at the census tract level and can be used to access neighborhood poverty levels. We use RUCA, which stands for Rural Urban Commuting Area Codes. These codes are classified by the U.S. Census that measures the population density, urbanization, and daily commuting. These 10 codes offer a relatively straightforward and complete delineation of metropolitan and non-metropolitan areas based on the size and direction of primary commuting flows. So in rural communities, you have limited health care, high poverty rates, unemployment, and health disparities compared to those that live in urban communities, have better schools, access to transportation, more healthcare providers, and higher employment. As you can see, looking at the picture, the urban population is more of a city base, and rural is more lands and houses are spaced out. So we know diabetes is a long-lasting health condition that affects how our body returns food into energy. Diabetes is the 7th leading cause of death in the United States. Number 1 cause of kidney failure, lower limb amputations, and adult blindness. 34.2 million Americans have diabetes, and 1 in 5 of them don't know they have it. Diabetes prevalence is approximately 17% higher in rural areas than urban areas. So the purpose of this study was to evaluate whether the association of neighborhood poverty level with the prevalence of diabetes differ across urban and rural communities. We hypothesized that neighborhoods with a higher poverty level will have a higher prevalence of diabetes. This association will be stronger in rural areas compared to urban communities. So in order to answer this research question, we used data from the Reasons for Geographic and Racial Differences stroke study. This longitude study had a total of 30,183 participants from 48 states and the District of Columbia. About half were Black adults and about half lived in the Southeast region. A full exam was conducted inside of the home, collecting the blood, the urine, the weight, the height, and medication. Additionally, each participant residential address was geocoded and linked to the 2000 census to obtain the percentage of households from federal poverty level for their census tract. After excluded participants, missing diabetes and other variables, an address could not be geocoded. This analysis included 24,752 participants. So the primary exposure was neighborhood poverty level. Neighborhood poverty level was divided into quartiles, with quartile 4 having the highest poverty levels and neighborhood poverty level was defined as fasting glucose. The primary outcome was prevalent diabetes. We investigated this association across 4 types of communities: higher density urban areas, lower density urban, suburban, small town, and rural. We used modified Poisson regression for our statistic analysis. Models were unadjusted and adjusted for demographic and clinical factors. As for results, the participants in the regard study, the overall mean age was 65 years at the baseline, and 55% of the participants were women and 40% were Black adults. 41% lived in a lower density urban area, followed by the rural with 20%. The higher density, 19%, and suburban small town, 18%. Higher density urban communities, 70% were Black adults compared to in rural communities, 21% were Black adults. The prevalence of hypertension was 64% among those living in higher density urban communities compared to those 56% that live in rural communities. Also, higher density urban communities had higher smoking and BMI than rural communities. The distribution of neighborhood poverty level across the community types. Higher density urban communities have an increase in neighborhood poverty level compared to those living in rural communities, have a lower poverty level. The prevalence ratios for the association of neighborhood poverty level with diabetes was stratified by community types in the regard study. For each community type, those in the most disadvantaged quartile had the highest diabetes prevalence than those in the most advantaged quartile. This association was partially explained by the demographics and clinical factors. For an example, after adjusted, those in the most disadvantaged quartile 4 had a 15% higher prevalence of diabetes than those in quartile 1, with a higher density in the urban area. So in conclusion, adults living in neighborhoods with a higher percentage of households below the federal poverty level had a higher prevalence of diabetes. This finding was present in urban and rural areas, even though the degree of the federal poverty level differed across the community types, suggesting that prevention efforts are needed that target the most disadvantaged communities. These preventive efforts could include providing access to healthier foods, better health care, more job opportunities, diabetes preventive programs, and improving the overall health outcome. I would like to thank the UAB Step Up, the NIH, the UAB School of Public Health, Step Up coordinators, Ms. Ann Smith and Ms. Dunn Pfizer, and my mentor, Dr. April Carson. Thank you. And here are my references.
Nice compliments there in the chat from Adam. I second those. That was a great presentation. And I'm so glad to see someone from Step Up and, the summer programs continue the research and to present here at the Expo. That's awesome. So congratulations on that. I'll start off with a quick question, and those of you in the audience, you can put it in the chat or you can raise your hand and we'll be sure to call on you. But again, I've been asking everyone, but I got to ask you too, the challenges of doing research during this COVID year, what was it like for you reflecting back on it?
It was very hard. Because I initially supposed to did my research last summer, and of course, COVID things changed, so they offer us to do year-round research. So it's supposed to start it last fall, but we didn't get to start to this spring. And doing virtual, it's definitely hard because I'm a hands-on person, so I have to kind of see it, kind of feel it, kind of get a better understanding of things. But that was a real big challenge for me, just kind of doing things a little bit on my own, of course with the help of my mentor, but it was definitely a challenge.
No, definitely. I'm sure. Is this something that you hope to continue doing research on?
Yes, I'm looking into furthering this research. I'm majoring in public health, so my interests are chronic illnesses such as diabetes, obesity, cardiovascular disease. So this is kind of like my area of my interest in public health.
And I know as part of Step Up, you usually have a national conference as well that you present at. Is this something you're going to be presenting at that national conference?
Well, due to COVID, we would have been presented Bethesda at the NIH last summer, but they switched things over to doing it virtual. So we'll probably do something via Zoom.
Okay. Well, I know there were a lot of challenges. So again, just congratulations on getting to the point that you are. It was really good. I mean, and this is really important, as Adam said. I mean, this is really important research, and looking at these correlations is so valuable. And man, looking at that large scale data, I mean, that's really great. Any other questions or comments from our audience?
Actually, I've seen surprisingly yesterday at the TV, if I playing with the channels, however, there was a subject similar where as a solution, that's my kind of point that I'm trying to make of what to do about this, lower income and areas, and solution was found that I saw happen to see at the TV. They were building groceries with fresh fruits and vegetables, and that gave the sense of a community, and everybody was actually painting the walls and building it all together, and storing all the food and stuff, and that actually improved the diet, therefore lower blood pressure and sugar levels and so on and so forth. So I thought that was actually pretty good, and we could do that too, because you don't need to drive whatever out of the neighborhood to just get something quick for the kids, or and definitely not, you're not going to give it to the kid no more if you need to drive 10 miles or so. So yeah, it's a very good topic, and a big problem that we all need to help and do something about it.
Thank you.
Great job.
Thank you.
Absolutely, super topical. And yeah, the building of those grocery stores is a vital part of it, and farmers markets and all those things. Absolutely. All right. Well, with that, I think we will go ahead and finish up block one. But thank you, Kristina, for presenting that wonderful research, and congratulations again. So thankful for you being here, and look forward to future developments and seeing you do other presentations. So thanks everyone for joining us. And again, we'll record. We've been recording, so we'll put up the recording so you can check it out later if you need to. Thanks again, everyone. Have a wonderful day.